Good morning, everyone, and thank you, AIOS, for the opportunity. So, I would be basically talking about a very important topic, probably that shaped our understanding about pathophysiology of myopia and emmetropization, as we all know, refers to a development process that matches the eye's optical power to its axial length so that the unaccommodated, the idea is here is to remember that's an unaccommodated eye which is focused as distant and is emmetropic. So once this is achieved, the eye growth enters homeostasis, maintaining a mild hypermetropia. That's what is actually happening. But any kind of disruption at this point can lead to ametropia, whether astigmatism, hypermetropia, or myopia. So as I said, it's a process that occurs mostly during first 4 to 5 years of life, with both initial myopia and hyperopia converging on low hyperopia by the age of 6 years. So by the age of 6 years, almost 80% of children are going to become ametropic. Emmetropic. And rest of them, those who could not match this process become ametropic. So how does this emmetropization occur? Is it a passive process or there is some active feedback mechanism going on? That is what this presentation is about. So as we all know that there are a lot of changes, and these are the parameters of newborn old child. You have very steep cornea there, very short axial length over there, a very highly convex lens, and an immature retina and ganglion cell layer. So as the child grows, there are changes. The axial length tends to increase over a period of time and reaches adult level by at least 5 years of age. There are corneal changes also. So the corneal lose its power, its steepening, it becomes more and more flat, and by age of 3 years, it has a radius of 7.7 mm. The changes occur both in the anterior curvature as well as posterior surface of the cornea. So the rapid losing of power over a period of for 6 to 7 years is what leads to the loss of myopia. So around 17 diopter of power is lost there. Lens also goes lot of changes during this period, and there is tremendous decrease in dioptric power of the lens, which was around 90 diopter at the birth and becomes around 75 by the age of 1 year, and later even decreases even more. It is proposed that it's an equatorial growth of the lens causing stretching of the lens, which flattens the curvature both anteriorly and posteriorly, and thus reduces the lens power. Along with the cornea and the lens changes, because the cornea is going little more anterior and lens is becoming little more flatter, there is increase in anterior chamber depth. So the depth grows gradually. While this is all going on in the anterior segment, in the meantime, the posterior segment is also maturing. So the retina takes its own time to get mature. The fovea develops by the outward displacement of the inner nuclear cells, and the ganglion cells. Cone migrates toward the center. As a result, the fovea contains only the cone receptor. So this process also takes its own time. It happens over a period of 2 years or so. So the cone density will increase with the elongation of the cone becoming longer and longer, and the rods being pushed more peripherally. The cone outer segment develops even more slowly. So the entire foveal maturation process takes almost 4 years, and that is the reason why not many children may have 6 by 6 visual acuity at the time of birth, or even at 1 year or 2 years. So it's around 3 to 4 years that they attain the adult visual acuity. Neurological development also takes place at the same time. There are development of visual pathway, neural cells in the visual cortex, and any kind of disruption at this age, we all know, is very critical and can lead to amblyopia and total disruption of emmetropization process. So this is to summarize how we achieve. So there are two ways of doing it. One is at the first oscillation, which starts with the myopic refraction, and then as gradually the time progresses, the eye becomes more and more hypermetropic. But is emmetropization just a passive process? Is it predetermined? Does it happen on its own? So there are two components. But the passive emmetropization occurs at its own. There is decrease in corneal curvature, there's thinning of lens, there's increase in axial length. So this is all is the balance between the changes in cornea and axial length, which is going to lead to emmetropia. But it is not entirely a passive thing. It is governed by a lot of other activities. Your visual acuity, your visual needs, surroundings, etc. will give an active feedback to the brain according to which the structural changes occur in eye. So it depends on the feedback of the image clarity from the retina that goes to the brain and causes changes in the eye. So visual, as we all know, visual deprivation from congenital disorders is now going to lead far and farther away from emmetropia. So this visual regulation of the eye growth, which evolves to achieve the refractive state, which is best adapted for that type of viewing. That does not mean that it will always be zero power. It simply means that whatever that eye needs and whatever that eye gets adapted to according to its visual surrounding is what emmetropization is going to achieve. So most of our experience or our knowledge about emmetropization comes with the experiment studies that have been done on animals, chicks, tree shoots, and other animals. So any kind of interference in the form of vision is known to disrupt the emmetropization as shown in various experiments. So if you put a convex lens and you become the eye myopic, the axial length tends to elongate. Vice versa, if there's a, the axial length tends to decrease. If there is a concave lens, it tends to elongate. So there are a lot of changes that is going to govern the emmetropization process. So the more hyperopic the eye is, there is a rapid axial length elongation. The less hyperopic eye is, there is a slower axial length elongation. So why does myopia develop? So as experimental studies have shown that the restriction of visual space of an animal will have similar effect as that of a concave lens defocus, which will lead to elongation of axial length. And probably this is the way that the myopia develops in human. At the same time, it's not just the structural changes which are brought about by the multiple biomechanical changes that transduce the visual stimuli related to the sign of defocus into cellular and biochemical changes occurring in retina. So this leads to changes in RP, choroid, eventually retina, leading to the altered eye growth and changes in refractive state. So most of the emmetropization is brought about by the age of 1 year. The process still continues at the slower rate beyond the age of 3 years until around 6 years. So, and most of the children will become hyperopic by 0.7, hyperopia was 1 diopter by the age of 6 years. So any kind of visual disturbances during this period or later on also can affect the growth of the eye. Why is it important to understand the process of emmetropization? Why? Because only then we will be able to prevent myopia. So we all know it has its own genetic predisposition that we cannot definitely change, but we can definitely modify our environmental factors, our visual acuity, and help in controlling myopia. So certain drugs can be, if we understand the biochemical process, we can definitely have certain drugs which can modify these pathways and help in prevention of myopia. With that, I end my talk. Thank you so much.
Thank you, ma'am. Any comments by the panelists? Dr. Ken, if you would like to. Since you have done quite a lot of work in pediatric eyes, can we have one hand mic, please? Sir, if you would just join us on the, it would be easier. Yes, sir. If you would just join us here. And meanwhile, I would request Dr. Siddharth to get ready with the next presentation, which is another important aspect, which is the genetics in myopia progression.
So I would say that it's a very, very nice talk that was just given, very, very important. So the understanding of emmetropization is essential if we're going to control myopia. If we don't understand it, then it's a bit like, people want to go on a diet, but they want to have laddus and pakoras and prontas. Then they want to take Ozempic, right? The thing is, if you have to understand the behavioral intervention how it affects emmetropization. I think we're going to talk about that and all the different treatments that we can give. But it was an excellent foundation. Thank you.
Thank you so much.